turn to an open question and answer session. And I'd like to invite the speakers to join our virtual stage here. We see Pintye has joined, Dr. Chi, Petru is in as well. Great. Waiting for Dr. Lola. Okay, super. All right, so I'd encourage people to continue to put your questions in the chat window. We have a little over 2 minutes, I think, to speak. Great, so let me first start with a question for Dr. Pintye. Dr. Pintye, I'm curious if you could comment on how you think the landscape for PrEP might change with some of the kind of longer acting formulations, so be they kind of injectable formulations or some of the more innovative, a little bit kind of further away forms of, kind of patches. And how do you think that'll change the landscape?
Yeah, it's such an excellent question, and I think, you know, we just have opinions about it now since the data are so few for non-daily oral PrEP among pregnant women. There's the one study going on with MTN for the dapivirine ring that I mentioned. I'm not personally aware of other studies among pregnant women that are looking at long-acting CAB or some of these other methods. But what we do find sort of analogous to the PMTCT literature is sort of the trailing off of PrEP adherence in the postpartum period, and whether these more long-acting methods could actually support adherence during that transitional period from pregnancy through postpartum. So I think it's very exciting that there's more agents on the horizon to give women more options, but it's definitely an area that will need plenty of more research to understand the pharmacokinetics and acceptability of new methods in the pipeline in this particular population.
You know, Ted has a question here for me about local initiatives and how do you get from the national level to the subnational level with some of those approaches that we're discussing. And I think that's a really relevant question. Thanks, Ted. I think that's a really relevant question in terms of this approach. I do think a lot of the principles still remain the same, though. You know, this analysis of missed opportunities. I think that while right now we're relying on the spectrum model to do that at the national level, I believe that UNAIDS is working on an instrument that will allow those estimates to be done at a subnational level, either at a province or district or even a facility. And so I think that being able to categorize those missed opportunities in that way, and then using facility level data or district level data to kind of identify those programmatic gaps. In some ways, it might be a little bit easier to do that just because the scope is smaller, and perhaps there are ways to kind of address more local issues in that way. I do think that implementation as well of strategies, I think is obviously ultimately facility based, and the ability to do that, including using like quality improvement approaches and so forth, really holds promise. And so kind of the cyclic approach, I think, is really critical.
So one of the questions that I was going to address is the one about peers. And in my program currently, there's a low enough volume that we don't have an opportunity to bring kids of the same age together at clinic very often. But when we did, we found that to be a very effective way to disclose to a child who didn't previously know when they've already become friends with another child with HIV. And so we had some very touching moments where we brought those kids into clinic together for the purpose of disclosure, where the new child immediately has a pal who has the same diagnosis. So that's been very effective, but we don't have a large volume to do that. I think it's one of the arguments for trying to cluster kids in your clinic of roughly the same age so that you can help them build a sense of community that they aren't the only person living with this virus.
Thanks, Anna. Maybe I'll just jump in here and help Ted out. So someone's chairing. Jillian, here's a question for you from Sarah Perry. I love the idea of STI testing to identify high-risk people living with HIV to increase PrEP uptake. What other risk stratifications do you think may work in resource-limited settings?
I think another great ongoing programmatic initiative is the distribution of HIV self-tests co-delivered within antenatal care to inform pregnant women of their partner's HIV status, so a secondary distribution approach. What our group has found in Western Kenya is that women who know that they have a partner living with HIV are actually, very, very accepting of PrEP. But the group of women who has a partner of unknown HIV status, that's actually one of the strongest predictors of HIV acquisition in our pre-PrEP work that was observational studies on HIV incidence during pregnancy. And so I think prioritizing that group, and there can be a lot of reasons why somebody does not know their partner's HIV status. The relationship could be new, it could be a relationship climate issue, it could be the male partner's refusal for HIV testing. But I think that co-delivery approach of the HIV self-test with PrEP offer and integrated fully within antenatal care is something that's scaling up in many places, and is a great way of promoting HIV prevention efforts during pregnancy.
Thanks, Jillian.
There's another question about schools, and I have a somewhat cute story to tell you about a child who knew his HIV diagnosis but had not disclosed to the school. And the concern that was raised was because people in the school, especially the teachers, were giving erroneous and outdated information to his classmates about HIV, telling them, for example, that you don't want to get HIV because everyone with HIV dies. And the patient had a limited control of his own anger, and he got frustrated and spoke back to the teacher in a way that was not well received. At the end, the teacher asked him, "How come you know so much about HIV?" And he quickly passed back to the teacher and said, "Because I know someone who has it and I've learned about it." He was still sent to the principal's office as punishment for talking back to the teacher, and to me to clinic in the next day and asked what he could do. And I showed him how you can connect to the internet, look at the CDC, any other source of accurate information, and you can print a list of how HIV is transmitted, how it's not transmitted, and what the long-term outcome is for people who take medications for HIV. I printed them and gave them to him to take to school the next day so he could show the principal what the truth is in contrast to what the teacher was teaching. And with that in hand, he was able to give back to the teacher some useful new information so that further misinformation would not be distributed. Gina, another question.
Okay, so we have a minute left, yeah? I can see we have just a minute left. In closing, I would like to say that with all the questions that I saw concerning disclosure, HIV disclosure is a process. I think that's just how to approach the issues. It's a process. It may not just be a one-time affair. It's something that has to be done gradually to assess readiness in the child, in the caregiver, in all the ramifications that we have discussed. If we're able to take this away and make sure that we set up a process in our clinics, I think we should be able to get it right. Thank you very much. That's what I have to say.
Thank you all for listening. We're sorry for these technical problems.